All right, ladies and gentlemen, let's go ahead and get started, and we'll get the event going. And as people continue to trickle in, I want to make sure there's a lot of room for networking, collaboration, a little general conversation as we continue on. So, propelling in the future using visionary leadership to elevate the art and science of nursing excellence. So first off, my name is David Jackson. I'll be just introducing us for the evening. So I'm a member of the HIMS Midwest Gateway chapter, and I'm a board member, and excited to be here. This is kind of the second thing I've gotten to MC this year, so I'm starting to enjoy it. Some of you I've worked with in the past, you know I enjoy a microphone, so I'm here for you. Let's talk about the chapter a little bit. I'm really excited about this chapter. We are a growing, exciting chapter. Oh, sorry, I'm supposed to stay over here. So we're growing in a pretty exciting chapter. As you can see here, we have a lot of positive momentum. We are 1,000 members strong. We have an active LinkedIn group. And while it's not quite Taylor Swift numbers, we for sure have a lot of likes, shares, and other things on social media. So please do take a moment to check us out. If you're not already a member, consider joining. Can any of our board members just raise your hand? Talk to any of us. We're more than happy to help you get connected with our local chapter, okay? Another big thing that we get to announce, and we've gotten to announce this all year, and we're really excited about it. We earned this past year the silver recognition. So HIMS 2024, we earned HIMS chapter recognition for silver status. It's an amazing accomplishment considering we are a small chapter. I think Scott, who is traditionally here, and forgive us, he's actually a little under the weather right now, recovering from a little procedure, but doing really well. But as he says, we're punching above our weight class, and it's true. And I'd like to see us continue to grow by what you see us doing like tonight, thanks to Tracy, things that we've done in the past. That helps us. It propels us into the next level. And so get engaged. We can do a lot of really cool, fun things here. We had an event a couple of months ago and someone said just the most profound statement. I truly believe it. If you want to see and be a part of healthcare innovation and change in this country, you don't have to live in the Silicon Valley. We have 4 or 5 major health systems right here. We have 2 academic health systems right here. Believe me, the future of healthcare is here. It's nowhere else. So stick around, join us. It's going to be a good time. All right. I can't get started without talking about a few more things we have coming. So if you're not already registered for any of these events, please take a look go out on our socials I mentioned before. Let's get some Taylor Swift numbers. Start liking some of our stuff. It'd be amazing, right? But at the end of this month, we have the Gateway to Innovation Conference. Next month or the first week, we have National Nurses Week. We're going to do, I've sent a few requests out, but we should be putting together a really cool summary of what makes you love being a nurse every day. And so that I'm excited for that. And so if any of you would like to participate in that, especially those of you that are nurses, I know there's a lot of you here tonight, talk to me. I'd love to give you my contact info. Send me your statement. We have a data sciences presentation coming up next month. I'm really stoked about this. This young lady from Technology Partners is flying in from Colorado. She's remarkable, has just an in-depth, she's the, Chief Data Science Officer. Has just I've heard her speak before. It's just remarkable. So if you're able to come out on the 15th, please join us. On June 19th, we have a hospital at home presentation. You know, we can think of the advancing healthcare system, right? What do we continue to see now? More patients want to do more from home, right? So what does that look like? It's not just post-acute anymore. It's not just, the hospice or any of those sort of home care opportunities. We're truly able to treat people remotely now. And so how do we do that? How do we continue to advance that? And then finally, although it's out of sequence here, don't forget, June 5th is our Summer Social. It's one of our most attended events. And if you want to just come out, have some amazing food, spend a little bit of time with some amazing people, please sign up and come out. This is something, it's free to HIMSS members. So it's almost worth joining just to be able to come out and enjoy the camaraderie and the collaboration that exists there. So consider that as well. All right. A huge thank you. This event and events like this don't happen without amazing sponsorship. And so first off, I have to say thank you to Microsoft. They are sponsoring this entire event tonight. Even if you aren't a HIMSS member, I believe, they have taken care of all of the costs for you to be here tonight. So just a big thank you. I'd love it if you would just give me a round of applause for Holly, Renee, Amanda, thank you all for being here. Others?
Exactly. Everyone says time. And I picked on you, Carol. I know that you would like some time. I would like some time. Everyone in here would like some time. The other question I ask is, how many people in the audience are nurses? Okay. And if you aren't a nurse, you tell you know, or your mom was a nurse, or your dad is a nurse, and we all owe you all a lot of gratitude. But along with nursing comes the need for more time, and that's what Tracy is here to talk about today, is how we're providing not only physicians in our workspace with the additional time, but also nurses. And now it's up to the health systems to leverage that time to provide greater well-being back to these nurses who have given so much of themselves to us as patients. So I'm going to turn it over to Tracy. Thank you all for joining us this evening. And we're not taking that food back, so please enjoy yourselves and enjoy Tracy's presentation.
Before I leave Tracy, I do have to do a couple more obligatory shout outs here. So additionally, we do, every one of these events has some participation with some of our regular sustaining chapter sponsors. So I do love to make sure we call them out as well. So if you're here tonight from one of these groups, if you wouldn't mind, just raise your hand, because I ask each of you to please, take a little time. If you are a consumer of technology, try to connect with some of these people, give them a few minutes of your time and talk. They bring some amazing offerings, right? All right. And finally, this is, as we look at tonight, this is an official order of business that we are able to grant 1 hour of CE for HIMSS CE. So you are able to utilize this for being here tonight and listening in. So without further ado, it's my honor to introduce you to Tracy Breece. Tracy is an executive director of nursing informatics for Mercy. She's a pioneering nurse informaticist with over 25 years of leadership experience, leveraging innovative technology to enhance nursing practice and patient care. Her unique blend of clinical expertise and digital proficiency enable her to drive transformative changes that improve healthcare outcomes and operational efficiency. You see, Tracy holds a master's degree in nursing with a focus on healthcare leadership. She is ANCC board certified and a certified professional in health information management. Ladies and gentlemen, please join me with a warm welcome for Tracy Breece.
Thank you all for being here today, Dave. Thank you. Thank you for Holly. Thank you for Microsoft for having us all here. Honored to be speaking with you. So the entire conversation this evening is about us together. This really is more about what we're seeing in the industry around nursing and how we can work together to improve the lives and the well-being and give back that time. So for those of you on the call, I have a mic on. I walk and speak, so I'm sorry. I'll come back to the podium. But can you hear me? Thumbs up for the folks on the phone if you can hear me. Okay, there we go. All right. So nursing has always been a profession about balancing. We balance critical thinking with compassionate care. We balance clinical demands with human connection. And now in the modern era of technology, we're balancing all of this technology around us and how we can most effectively take care of the patients and do what we do best, and that's take care of those who need us. So today we're at this intersection, nursing, technology, and the advent of enhanced artificial intelligence. So I'm going to talk about 4 key projects that we have built with nurses alongside exceptional partners and exceptional data scientists, many of whom I think are probably in the room. So one of the things I want to do first is to get to know everybody that's here. So if you on the phone can either do the QR code or the link, and if you're in the audience, if you would be so kind to take the survey, that would be great. So I talked about this intersection of nursing technology and leadership, this reality of the sheer volume of information and data points that we have available to us in this overwhelming sense of decision making now that nurses have. So once you all are done with the survey, we're going to talk quite a bit about my personal journey, the journey I've been blessed to lead at Mercy around nursing innovation, and a little bit more about you. So we'll have polls throughout the survey or throughout the conversation. So I'm going to see if this works. There we go. So getting to know each other. So 50% so far, nurses, 50% IT. As folks are answering. Thank you for answering all of the questions. So as leaders and IT professionals, as you are continuing to answer the questions if you haven't, what we're talking about is simply beyond, I'm going to move through all of these. Simply beyond these new tools. And this is a great slide for me to touch on. Later in the presentation, we're going to talk about concerns, talk about reliability and data privacy. Okay, good to see. We're in good company. If nurses are using AI tools, if you're considering it, that's good. Majority. Generative AI, 25% of you. That's fantastic. 42% are considering it, but another 28% are using generative AI tools for other non-nursing workflows. Okay. So let me see how we can move through this next slide. This is the first time I've done live polls, so thank you. All right, so Holly, I might need your help, my dear, because it's just staying stuck on the form. No, I want to get to my presentation. Okay, so we're going to come back to that while Holly gets my next slide up there. So the first thing I'm going to talk about is a little bit about who I am. So as a young adult graduating high school, nursing was not my first career. I was in cosmetology school. I was learning how to do hair, makeup, and nails. I'm like, this doesn't really sound like me. I want to do something else. So then I tried television and radio. That was my very first major at university. I did that for a year, and as most young adults, we need to make money, right? So I was nanny, and I was nanny for a registered nurse, and she was an ER nurse. And about a year in, she's like, you know, Tracy, you don't seem to be pretty happy with your television and radio major. I think you would be a great nurse, and let me tell you why. Your curiosity about what I do for a living, your understanding of people, and how you talk to my children and meeting them where they're at their developmental age, and how I implicitly trust you. All of these things are 100% the core of a nurse. So at that, I'm like, well, Janet, kind of convinced me. Let me go to university and see if I can switch my major. So that gave me 5 years of undergraduate because I switched. And nothing in television and radio transitioned over to science, school of science. So that is a little bit about my personal journey. So why Mercy? When I was in my undergraduate program, the Palace on Dallas that delivers a lot of babies, that was my rotation. And that was how I was first introduced to Mercy. When you're a student at Mercy, you learn about the fabric. You learn about the values, dignity, justice, service, and excellent stewardship. You learn about the mission and vision, relentless pursuit to getting healthcare right. And was founded by the Sisters of Mercy, who are Irish Catholic nuns. And my family is incredibly Irish. For every single family event, we say Irish blessings. And I'm like, oh my gosh, this is where I'm going to work. When I am done with my degree, this is where I'm going to hire because it is who I am. And at the time, I didn't know I was going to be standing here 28 years later talking to you all about why I chose Mercy, but I'm fortunate and glad that I did. And why I chose nursing. So let's talk about the Mercy nursing strategy. we have our Chief Nursing Executive Officer. 3 years ago, she determined that we needed an emphasis on nursing informatics. At that time, we had 0 nurses in any role on informatics. Yet we have a mature health system. We have an exceptional EHR that Cheryl, one of my colleagues here in the front row, designed and built about 16 years ago. And she believed that nursing, specifically the discipline of nursing informatics, it was time to emphasize what innovation can bring to the future of nursing nurses. So that was the birth of me and my role, and the strategy: balanced workflows, balanced workforce, balanced work environment. So think about that. I led with balance. Nurses balance all the time. And now we have the modern healthcare world requiring us to balance in a different way. And she knew, she had the foresight that technology, as rich and as great as we still weren't missing the mark for nursing. So her vision allowed us to create goals and expectations around a strategy to deliver key projects that we first started around time. And we weren't the first. So let's talk about one of the elements with Mercy's innovation approach. We have an innovation unit that is at Mercy Ballas, and we have a second innovation unit down at Mercy Hospital Springfield, and we have a third and fourth being cultivated because of the success of the first innovation unit. We thought at the time, and Joe Schmitz is a colleague for Mercy. If you're interested in learning more about the innovation unit, he is the person to reach out to. But we thought at the time, well, we'll just have 5 beds. We'll run innovation, small cycles of change with these 5 beds. Well, it's a 35 med surg orthopedic unit, and that didn't quite work. Because how can you do 10 cycles of change on a few limitations of bed, and we have one infrastructure for our technology base. So running parallel systems and parallel tests just doesn't work quite well. So the whole unit became the innovation unit, and it became the playground for us to begin cultivating curiosity, cultivating the spirit and the possibility of what's possible. It wasn't fancy. We didn't start out with technology. We started out with things like, what makes your job easier? Well, can you put an IV pole in every room? Can you move the supplies around? Can you order the supply shelves like this? Can the Omnicell cabinet be stocked in this way? But we didn't know that until we started asking the questions and involving nurses and asking them, what do you need? They didn't come right out the gate and say, can you create a generative AI nurse inpatient handoff report? That's not where we started. We started very small and very simple. But it has allowed us to cultivate a team where we can have a focus on AI. You've already done the polls. And we talk about, so what does AI mean for nursing? We all have seen and heard fear. Why we do what we do is to support clinical decision-making. It's to give nurses an assistant. Copilot 365 was my assistant, right? Helps me be faster, my PowerPoints, helps me be faster in my email. We wanted to give back as an assistant. That's what AI is going to do and is doing. In a moment, we'll talk about application outcomes too. So with that, so there was many in the room that talked about doing something with AI for nursing. Have you all, raise your hands, who's done it? Because there was several folks, not to call on you, but I'm going to. Thank you for being so brave. So AI in nursing, how'd you start?
So I actually work for Mercy as well. Side of things. So value partner. Let's expand the topic.
Fantastic. So non-clinical
Yes.
value partnership.
Yes.
Fantastic. Fantastic. So one of the things that we did for 24/7 hour nursing is a project called Anew. Post-pandemic, we had an environment in our healthcare system where nurses were stressed, patients were stressed, everybody was stressed. The minute as a nurse you have a patient dying alone, and it's a repetitive thing, you lose yourself in what just happened, because that's not what we do. We hold hands and we touch our patients every single day. We provide that compassionate level of care. And so the nursing profession was upside down because of the environment that we lived in during the pandemic. So Cheryl and I, under the strategy of Project Anew, went out to our facilities. And Anew stands for Advancing Nursing Efficiency and Workflows. And it was all about our CNE handed us a paper and said, hey, UC Davis did this really great work around time, Holly time. They gave back time. Do you think that's a problem for us? And do you think we can do it? We're like, we don't know. We don't know. Let's go out and ask the nurses, because we don't want to presume what they need, but we know they're hurting. So for the better part of 12 months, we went from facility to facility to facility for over 50 hospitals. We only went to about 13 in that first year. And all we did was do listening sessions. We didn't come in and say we were going to solve their problems. We didn't even pretend to know what the problems were. And there were 2 tracks. One, leadership track. So interview the leaders and ask them, what are their problems? What's their friction? What's the day in the life for you? The other track, we had nurses out on the floor shadowing nurses, gathering just copious amounts of qualitative data. All of this was qualitative data. And at the end of each of our visits, we would summarize and we would send back to the CNO, this is our experience. How can we work together to make the environment and the well-being of the nurse improved? So it was a shared contract. We're going to do this, you're going to do that, and we're going to deliver. Our promise is we will deliver. And so we started doing easy things. And we talk about, do you think you can take this flow sheet and just not make me document it 5 times? Yeah, we sure can. Sounds like a great idea. So little things in our flow sheets in our daily work, which we really didn't know we had that massive of a problem. At the same time, we looked at our nursing efficiency data from our EHR partner, Epic, and that told us that we were really unhealthy with the time that we spent in our EHR as compared to other organizations our size. So that project resulted in efficiency time saved. The start of the project, 220 minutes, higher echelon of a nurse just simply document. Transitions and clicks, that's all I'm talking about, transitions and clicks. 220 minutes. The average was about 167. So today we're at 132 minutes. We have sustained that for the better part of 2 years, and we have given back that time. That is real time. So that is what started our process around efficiency. During all of this work, what we've done is we've created trust, credibility, and engagement across our health system. So we have one network. We have one EHR. Sure, we have some variation with peripherals and other integration devices, but for largely, our goal is standardization. And so when it's a problem in one facility, or we change something in Northwest Arkansas and Rogers, we change that for everybody else. So we have to think about change management and what that means. They're used to seeing Cheryl and I, and they're used to now, because we've been there, we've felt it, and we've learned with them post the pandemic, and we've delivered. They're used to saying, oh my gosh, they're here to make our lives better. They're here to improve. So our Class Arch Collaborative Survey is a nurse well-being metric for us. We moved over 20 points in well-being in 3 years. Now, we're still not at the pinnacle because that's how far down at the bottom we were. But we've improved year over year, and our nurses are telling us that. So when we talk about balancing our human-centered care, it's important for some of the nurses that work with us every single day. It's important when we think about the foundation of the work that we laid and building a trust factor when we start thinking about now generative AI is here. And our fabulous nursing technology team and our data scientists are willing to partner with us and do something with us. The nurses are like, oh, okay, they've been working on well-being for us. They've been listening to us. They've been changing things. Yeah, I want to come along. Oh yeah, we have an innovation unit because we're investing in you. We hear you. You're at the table. So these are the things that we do every single day. And the quote from the nurse there, this technology is here and the tools are here to support me. See, they're sharing that with us. We had a nurse leave Mercy recently and came to a competitive here in the St. Louis went to a competitor in the St. Louis marketplace. When she came back, the question was, okay, you left and came back. And she goes, well, I was working every single day. And I was asking myself the question, where's the technology to support me? Support my balance with critical thinking and compassionate care. So when someone asks me, is your strategy working? That's the answer. Someone chose to come back, and she articulated what we are attempting to accomplish in our organization. And not just our organization. I'm here today, Cheryl's out. Several of you talked about hearing us in other forums. We're here to uplift the entire profession. I'm so deeply proud of being a nurse and having the privilege to be a nurse and work with my team at Mercy and say, hey, let's make it better for them. So, nurses as key players in AI. Who would have thought nurses could design technology? We sure did, right? The advent of the EHRs, what we did was say, okay, IT, just go build it. I don't know, just go build it. And then they gave it to us, and we're like, wait, what'd you do? And they're like, wait, you told us to build it. And so we're overcoming that. And we think about when nurses are at the table, you can hear from your lens, what are the workarounds that we've had in our work environment? And automatically, every single person around the room is saying, oh my gosh, I can do that better. Oh, you mean when I designed that button there, you look left and not right? Oh my gosh, I can move that for user interface improvement, right? All of those things. When we think about designing AI, what we're designing and listening to them is, when you asked me to automate on the advent of the EHR, when you said, hey, Tracy, can't we automate that? And can't the computer help me? They were already there and they didn't even know it. We didn't know it until NVIDIA made some really cool chips and we can use that power to generate some generative AI. So I'm going to talk here in a minute about one of these things, and it came up in the poll, resistance to change and fear. So for us, we had this broken base. We had nurses at our elbows telling us how to improve, and we were improving in their daily life. Once we started filling in those holes, the fear equation was diminished just a little bit. No, they weren't fearing anymore. Someone was going to deliver a product that was built for me, but didn't ask me, because they're here asking me. And they're not just asking one person. They're going around our entire facility and they're talking about it. The chief nursing executive is talking about us being in Rogers, in Portsmouth, in Ada, in Ardmore, in St. Louis. You name the location of our footprint. They're talking about us being there. Yes, we're leaders, so we're actually, engaging with the CNOs too. We're not just showing up. But we also ask them, this fear, now that we're here in generative AI, of job displacement. No one was afraid that we were going to take their jobs away because we had already proven for 3 years that we were here just to make it easier for them. The other thing that we did around fear is distilling, quite simply, what generative AI is and what it isn't. Very clear. This is what it is, and this is what it is not. The other thing we did very first around education was normalize it. What I mean by that, Netflix.
Instagram, YouTube, done. We talked about it. We talked about all of the AI in your everyday life. And so when they started thinking about it, and they're like, oh, you mean it can cross over into my professional life too? Oh yeah, and they're asking me about crossing over in my professional life too? And oh yeah, I've had experience over here in my personal life, what I don't like about it, and I can talk about it over here, and then I can see it. It just naturally evolved. We do not have an end user disacceptance or unacceptance of generative AI. And I'll talk about the numbers here in the next 4 projects.
So workflow integration, I'm going to stand at the podium for a second because I know everybody online can't see me. So the workflow integration, one of the most important things that we do when we have nurses at the table is process map. From the second the patient enters our footprint, whether it be a clinic, an ED, a hospital, and we process map it all the way along. Sorry, I said I was going to stay at the podium, but I'm not gonna. I'm sorry, guys, it's not me. I have to walk. We process map it all. That's what we've learned. Is if you don't do that journey, you miss key stakeholders along the way when you're designing a process. This isn't new. It's project management 101. It's process mapping 101. But we didn't have a really good hygiene about that until we really started inviting nurses at the table. Ethical considerations in AI. I was chatting at the start of the meeting a little bit about this. And we are blessed to have Byron Yount. He is our Chief Data Analytics and AI Officer. From the very beginning, when we knew generative AI was going to be a possibility in healthcare and health and life sciences, we volunteered, he specifically, as well as our senior executive team. Let's learn more about this and what's our framework going to be. So we were early members and founding members of TRAIN. We are also members of CHI, Coalition of Healthcare AI, TRAIN, Trustworthy, Responsible AI Network. Very early on, both of those organizations, we were at the table. And what we learned is what are the things that are in common around ethical principles and guidelines, and how are we going to make it part of Mercy? And how are we going to instill that into the mission and vision and build that into our IT infrastructure? And so here is our framework. Here are the domains. And we're learning every single day alongside all of you. No one understands it 100% yet, right? Because it's so emerging and new, but learning together and allowing us to say, hey, we have ethical principles. We have a framework. When we are building generative AI, we have checklists. We have the hygiene about us to go back to these principles to make sure that we're tying all of this off during the design process. Not when it's live and we're like, oh, wait. With the exception of one, because the CHI checklist wasn't available when we went live with our ED inpatient handoff. Chelsea West, a colleague that's on the phone with us, brought us through that exercise after it was live, just because it didn't exist. All right, so we talk about the barriers. I talked about our senior leadership engagement. I have had the fortunate opportunity to not only learn from all of you in the industry, but also Dr. Peter Lee and John Palanca. Our senior leadership team invited them to Mercy to speak to us. So I was in the audience as a member of the leadership team, and I got to hear from them. And I got to hear about what generative AI is, and that was my first education session as a nurse. As a nurse and a nurse leader, I was like, wow. So at that point, when I walked away, knowing where our nursing strategy is with our balanced workflows, balanced workforce, balanced work environment, generative AI is a thing. We're going to embrace it. I've got to learn more. So I called Cheryl. I said, Cheryl, we got to go to university. We got to figure out what this is. A really smart thing out there. Dr. Peter Lee, Dr. John Palanca, got to go. So the two of us registered in MIT's AI and Applied Healthcare education course. It was 4 months, I think. We got a certification at the end, and we learned alongside MIT professors. So we could continue to upskill ourselves. The importance of that is when we're met at the bedside,
and a nurse says, oh my gosh, this technology is creepy. I can talk about that. I can talk about overcoming that creepiness. So I'm not here saying we don't have challenges, and I'm not here saying that we don't have those conversations. What I'm saying is how we overcome them is being confident in upskilling yourself and going through the education and training, reading, even if it's just 10 minutes a day. LinkedIn has a lot of good stuff that's real and it absolutely is meaningful information. Do that. Invest in yourself and invest in the nurses that you're privileged to lead. One of the most important things, and I've referenced this a little bit, is our feedback loops. We can't ask nurses to come to the table and not tell them how it's working and not tell them what their feedback has done. And so that's a really big lesson learned for us. This constant feedback loop, how we administer that is through what's called huddle notes. Those huddle notes are at the bedside delivered by the nurse manager. Evidence and research indicates that a nurse will listen more intently and want to follow from their direct report. So Cheryl and I, when we go to the huddles, we don't talk. Kaylin sees us at the huddles. We don't talk. We're invited in to talk by the nurse manager if the nurse manager needs us to brainstorm. Because evidence and research says direct frontline teams listen first and foremost to their manager. So when we talk about these feedback loops, not only do we give those feedback loops to the front lines, we also give them to our senior leadership team. So at the end of every week, I write an email to our CNOs, tell them what's happening, I do the executive summary, and then the same one, I go to our SLT, Joe Kelly, he's our senior leader from technology, I rewrite it for him because I'm putting myself in his position, I'm putting myself in her position, what matters to you and why, and I want to give you that executive summary. I'm not going to give you the same thing I just gave in huddle notes, but I'm going to give you the talking points. So you're engaged and you can continue to sponsor us. Cheryl and I have 0 direct reports. Everything we do is leading from influence. Everything we do. And it's the hardest, most time consuming and intense part of trying to move an 11,000 nurses to a future state. So I talked about, I'm going to reference my paper so I get the numbers right. 4 projects. So what 4 projects have we done? The first one, I'm going to go back to Project Anew. The first one, we had a fall risk scale called Hester Davis. Cheryl and I were asked, I'm not sure who Hester is, not sure who Davis is, but I'm not getting falls right. Can you fix it? And we heard it over and over and over again. Can you fix falls? Can you improve this for us? So we leaned into our partners. We wanted to know our software portfolio catalog, and that led us first to our EHR. One of our foundational partners, Epic, and what we learned they had a predictive cognitive computing model for falls that we've never taken. But other facilities did. So we got on the phone with Texas Health Resources, we got on the phone with Northwestern, and we said, okay, we're interested in doing this. Help me understand what worked for you, what's not working for you, and then we can understand, is it a match for us in the AI category with our ethical and AI principles? Is it a match for us related to what it is we're trying to accomplish with our patient and nurse well-being? And it was. So what did that do for us? From a quality and safety perspective, we measure patient outcomes per patient day. It's gold standard. We were above 0.4 patient falls with harm per patient day prior to this. Afterwards, we are below 0.2 and have sustained below 0.2 for 13 months. And 4 consecutive months, we were at 0.11. That is over a 60% improvement in direct patient care. And falls, if you want to talk about money, falls are huge in an organization. So that's the talking point we have with our CFOs. We're, again, not perfect. Our goal is 0. Our goal is 0. But boy, have we sustained that change and have we made a difference in the lives of the nurses. We got rid of Hester, we got rid of Davis, we retooled our interventions, and we're now improving our patient outcomes. Second project. So that's where we started. Who's our partners and how can we partner together? Foundational to our work.
So that led us here with our Microsoft team and our mentors for our second project. We were invited, and the team here at Microsoft and our Amanda was here. I think when you were here that day, but Amanda was here. A whole bunch of other team people here mentoring us around what are we trying to accomplish. So we got the phone call and said, and I do need to tell you this, nurses weren't first on the list. Carrie Bomarito called me and said, hey, we were going to go downtown to the Microsoft Technology Center. The physicians backed out. Do you think the nurses have anything we want to do? We're like, we want to be there. We had 72 hours to prepare. So before that, though, everything that we do, we lead with evidence. And we already knew at that point, remember that foundation was so broken that all of these listening sessions, falls was on our list. So our professional practice council member and leader for our Evidence Center for Evidence-Based Inquiry, Jill Size, had all of this literature for us, all of this synthesized literature. What is an effective ED to inpatient nurse handoff? And so Chelsea and our data scientists from Mercy came down here and they built it. In one day, we built a proof of concept generative AI ED to patient handoff with real patient care studies. It was fantastic. Kaylin, you were here that day. We have this picture of nurses, 5 nurses, 5 of us. Now we had all of the research and we had the voice of all of the nurses from before, but boy, we were pumped when we left that day. But I will also tell you, Cheryl and I, from a technology perspective, we're like, something new. And then we did, and we're like, oh, it's prompts. It's prompt engineering. That's cool. What else is it? And it's a lot of complex things that Chelsea can tell you all about. But we're excited to learn a lot. So where are we today? With that hackathon, it was, we're currently sitting today at 77% adoption rate. It's phenomenal. The same for over a year. You're asking yourself, where's that other 25%? Why, Tracy, why are you happy with 75%? I'll tell you why I'm happy with 75%. Because we go back to the evidence. The evidence tells you that effective communication happens between people. In our critical access hospitals and our ICU transfers are so sick that that's still a nurse-to-nurse handoff. We didn't replace that. We don't want generative AI to replace that. So when we talk about fear and job replacement and displacement, we're not taking that away. Keep doing that. Continue to do that. So that's when we go back to it being an assistant. And so we proved it. Proved it. Okay, third, again, who are our partners? Foundationally, Epic or EHR. So we went back to Epic and we said, we have a problem we're trying to solve around care plans. Can you help us with that? We learned that they were doing something in their generative AI portfolio themselves around the care planning process. Care plan, the Joint Commission, for those of you that may not be aware, the Joint Commission comes in and basically is the organization accrediting body that allows us to keep our doors open. Well, if any other of the healthcare facilities, leaders across our footprint and shared company tonight, get the report outs from the Joint Commission, we always failed on the element of performance following our policy around the nursing care plan process. So we're like, I wonder if this could help. So falls, win-win, ED to inpatient handoff, win-win. I wonder if this could help us. So for the better part of a year, we designed that model with Epic Medicine developers. We are live. We've been live scaled across our entire footprint since March. And we are currently, as of today, 86% adoption. 86% adoption in less than 30 days-ish. That's huge. You know what nurses are telling us? They're saying, this is so easy. You mean everything that I documented and that critical thinking that I've had balanced in my mind that I never took credit for around my care planning process, ADPI, assessment, diagnosis, planning, implementation, evaluation. You mean all of that is going to be served up in a nice little draft note that I can read If nothing gets auto-filed to the EHR, I, still human in the loop, are there to say, yes, this is great. And not only is it giving us what we believe will be our first joint commission survey without any care plan issues, and our quality leader, Lori was on the phone with me this week and she's like, Tracy, I can't wait for the next joint commission survey. I said, I can't either, because here's another staggering number. No, you said it, no one. Yes, I am. But here's the other staggering number. We had a 279% improvement in filing our care plan progress notes.
Doing care plan?
They're doing it. They're doing that. So yes, we want joint commission. And the state and whoever else cares. So that being one of them. Fourth project, again, who are our partners? Microsoft and Epic. And so we're at the table in a private preview relationship around conversational AI. What is conversational AI? It means a nurse has her phone, she hits a button, in her pocket, does all of her work. It's done, and then it files to the flow sheet record. That's what we're doing with our partners. What are we learning? A lot. A lot. I started in the beginning around compassionate care with nurses. On the very first day, a nurse did this, dropped in her pocket, recordings happening, 38 minutes in that room, recording. Patient needed a revision to surgery. It was a bad situation. At the end, she's like, can you pray with me? And not only pray with me, can you pray for my surgeon? I know my surgeon doesn't want to take me back to surgery either. And I know this was a mistake for him and it was a mistake for all of us. Can you just pray? So we did. Guess what happened? The EHR filed spiritual interventions, which we never, ever would have taken credit for prior to that day. So tying it all together, my care plan, my spiritual interventions, listening to the patient, my pain reassessment, all the things that we're talking about and that we're doing are now being captured without me having to remember to do it. Give you some more examples. This is just the most exciting part to be here to talk about what we learned very early on in our private preview. Apple juice. We give apple juice with meds. Standard. But apple juice is also a laxative. So when I talk about being constipated and I talk about you not having a bowel movement in your BM a few days ago, and then I talk about giving you apple juice, and I had built in my EHR an intervention for constipation is apple juice, guess what happens? It files. Never would have taken credit for that, ever, because I was just giving you meds. You asked for it. I didn't put it together. But the AI did. Right? Okay. Let me give one more example. And this example is the most profound. And Caitlin's gonna remember. So the conversational AI ambient voice only works on an operating system of iOS. For many reasons, we've had an Android platform deployed to nursing, but our iUnit received iOS, and our iUnit is piloting, private previewing, building, designing, co-developing, however we want to phrase it with the other teams. Alex is hard of hearing, and Alex has hearing aids. She's a registered nurse at Mercy. She was pulled the iUnit on the first day we went live with conversational AI. Two things happened for Alex. One, as a nurse who has certain abilities, our environment was not meeting her where she's at. She bought and invested in a Bluetooth stethoscope that she cannot connect to Android phones, but guess what she was able to do immediately? She connected that stethoscope to the iOS. Bluetooth connected. What she said was this: I actually feel more confident in taking care of my patients because I can hear better. Not only is she able to do that, she's able to read the transcripts that come through the conversational AI directly in the EHR, because up until that moment, she knew she couldn't be the best version of herself because she was missing things. And we still have a ways to go with Alex. Alex doesn't work on the home unit and the eye unit, but she was able to experience this. And every other nurse that is in your facility that has certain abilities will have this experience as this matures. What better gift were we able to give her as a human to a human choosing a career of nursing? It's exceptional. Every single day, we learn something new about putting AI in the hands of nurses and empowering them. Empowering them. I talked about measuring success, and I think I'm running out of time, so I'm going to go to my closing slide. So this is about, what does it all take? What's the recipe? The recipe is different people with different skill set, committed, empowered, fully endorsed by the senior leadership team to improve. That visionary leadership, where are we going? How are we advancing the art and science of nursing? Why we're invested in nurses and talking about it and inviting nurses at the table, listening to their voices. I mentioned a moment ago, Dr. Peter Lee. You know, it was either him or Dr. John Longa, and I can't remember which one, so pardon the misquote, but it was one of them, basically said, if you don't embrace AI, it will run you over. Mark, you were there, so maybe you can keep me honest with you and tell me who it was. So, embrace it. It's here. It's permanently here. We cannot run and we cannot hide, but together, we certainly can be stronger. I talked a lot about nurses' role. Have us at the table. We're going to tell you every single time what's working and what's not working, and we'll tell you about our workarounds too if you really want to know, because then you'll be able to design and build things look quite a bit smarter. Fostering this culture of learning, that starts with us. That starts with our commitment to learn something new every single day. So if we're going to be leading a cohort of nurses or a cohort team in a clinical care setting, we have to invest in ourselves first. Sort of like that on the airplane. If you don't put on your child's emergency airway mask until you put yours on first. Put yours on first here. Invest in yourself. There's tons of literature. I have a synthesis table on AI and the impacts in the nursing workforce. If you're interested, I'll give it to you. I'll give you all the articles. Read hundreds of them. I will give that to you. And then lastly, I want to close with, every year I do something to invest in myself, but more on the personal side. Last year, it was a gratitude journal. Every day, I wrote in my gratitude journal, those high stress days, what are you grateful for? I don't know, nothing. 5 months. I was grateful for something every single day. Every single day, I really did. I reflected on it. I can't take credit for a word of the year because on LinkedIn, someone very profoundly in my network said, I'm going to choose a word, and that word's going to guide me for the year. So my word this year is brave. Raising my hand, speaking up, saying yes. Folks ask me, I'm brave. Also asked, how do you know you're changing not only a single nurse's life, but your profession? Because Tracy, I hear you every single time talk about elevating the art and science of nursing and changing the day in the life of a nurse. And I'll tell you, it's a feeling for me. So this week, Andrew was on site, he was visiting from the Microsoft team, and he asked me this question. How do you know? I said, Andrew, let's go out to the unit. Started walking around the unit. I said, how I know is that nurses are talking. I don't see that in their face, that stress and distress. I see the handoffs at the bedside happening effectively. I look at incidental overtime and it's down. I look at my data around the health meter with time spent at the EHR, it's down. But for me, it's a feeling. I'm going to ask you all to be brave and be the eagle and soar through the sky. Be you and bring every single nurse that you have the privilege to contact with every single day to a future state, because I know we can do it and I know we can do it together. So thank you for having me here tonight, everybody.
Tracy, are you open to a few questions?
Yeah. Yeah.
Be brave.
Thanks, Tracy. You know, I could feel your passion for the topic and people you work with. And one thing, in listening to you, that kind of came to my mind is that we should think about AI more as augmentation. A good example, there's a sepsis prediction tool that kind of hung up on letting the MOD know what's going on, but the nurses were able to fill that gap. So you see, you still got to have that human loop, and nurses, you know, are doing it as well. So just a comment.
Thank you. Thank you.
Hi, Tracy. Great talk. Thank you. Can you talk a little bit about the data, and can you define for me how you got to adoption, what were your numerator and denominator, right? Because you went from 0 to they use it. So what's
Sure. Which particular?
the handoff, I think.
So the workflow is a nurse selects in secure chat the ED inpatient handoff and sends it to the phone. So everyone on the unit that is signed in gets an alert on the phone. So this, there's some curiosity in this, right? This was a change for us.
Yeah.
Because one of the problems that we saw and heard in Oklahoma City was one of our facilities where we had the most opportunity around patients coming to the floor, no one knowing the patient was there. Minutes and minutes and minutes. So what we were trying to solve for was an awareness throughput with the ED. Patients arrived on our floor with transport, and everyone knows not just the bedside nurse. And so our compliance officer, there was a lot of discussion about this, right? Oh my gosh, is this HIPAA? Is it a HIPAA violation? The answer is no, it's not. Because here's why. From our chief compliance officer, that handoff report is giving the minimum amount of information necessary to safely care for that patient. And every person on that floor has a responsible to answer a call line, has a responsible to answer to immediate patient conditions. So we're actually enabling higher quality care. So the adoption metric comes from the secure chat utilization, patients coming in on phone receives the alert. And we accept it. Great question. Because that actually gave a bit detail of the process in some of the others I believe to go through.
So are you pulling a doc phrase or are you pulling flow-sheet documentation?
No, we are pulling information from the ER visit only, from the medical provider team. We chose not to include nurses' notes. Chelsea, keep me honest. Chelsea's on the phone and she built it. It's her model. So Chelsea, please keep me honest. And Cheryl. So we're using the medical provider team's notes for behavioral health patients. We're also using BH intake. So it's very specific assessment for our behavioral health patients. And then that is exported out of Epic into our proprietary custom generative AI algorithm. And then it's going back through into Epic through HL7. And the thing that we learned about going back into Epic from the HL7, we were blocking HL7 codes. So when we were testing it, why is it there? Why is it there? Chelsea sees it. Chelsea sees it. Well, lo and behold, years ago decision, we had blocked certain things in our HL7. Cheryl found it, and unblocked it with Jim, and it's great.
Hey, Tracy. Hi, Tracy. Thank you. This is great. Can you tell me a little bit about alert fatigue with things going to the phone? And do you experience that when you're saying everybody gets the shift report? I feel like that's another problem I hear out there. Has that been a problematic for you with this?
So this particular workflow is only PT arrivals. So it's not shift report. Kaylin, it's right here at Mercy. She might be a great contact for you. So Kaylin knows our mobile platform ins and outs and understands the alerts. Alert fatigue on the phone. We don't have all alerts going to the phone. Like when you think about all of the different apps, and Marianne and I are working on a matrices, if you will, kind of what trumps what on our phone, because we still have some opportunity to increase that connectivity of how the 20 plus apps on the phone are working. So we have been very intentional with the alerts that go to the phone. It is not every handoff for this. It's only PD admissions, not all alerts go to the phone. Specifically, not all bed alarms go to the phone. That was a decision that we made because they're so audible. But yeah, we'd be happy to talk through all of that. But our mobile platform has been, when you think about our strategy, balanced workforce, balanced workflows, balanced work environment. In the environment category, the workflow category, understanding your mobile platform is essential, particularly when you get to a documentation system like conversational AI, where we want all of that to be. And we have an entire matrices, reports, another DBP table. I can be happy to send that to you too.
Hey, Tracy, can
That's what I was just looking for. Do you have it up?
Tracy.
Organizational optimization.
Yeah, Scott, we need a little more clarification if you can hear us here. What is OODA? You'll have to type it.
Okay,
Scott,
So
we don't hear you.
what I'll say, okay, so not knowing what it is, but I'm thinking about it being an authoritative body. Okay, let's just call it an authoritative body. I had spoken to Scott how you keep your executive sponsors informed and you keep the project life cycle throughout. We often talk about having a discipline of PMO, project management office principles about us, although we're not PMP certified. I would argue nurse informaticists largely are, we probably should just sit for the certification. We keep our executive sponsors and the authorizing sponsors of every single project informed continuously. And with the advent of Microsoft Copilot 365, my executive summaries like this. So if you have it and you're not using it for executive summaries, I'm putting in a plug, use Microsoft Copilot 365.
I looked it up.
Okay.
It's a framework decision-making model. It's like our PDSA.
Okay, so we follow the IHI PDSA cycle, and yes, happy to go in depth with that, Scott, Rich, but yes, we have that. We have the forums and the peoples and the communication processes to keep that feedback loop open to all key stakeholders. And not only do we use data and analytics, we also invite our leaders to shadow with us and come to the departments with us.
One of the questions he was asking, we start in this one unit, we started it on a single floor, that's what it sounded like he was asking, like.
And we scale up.
Prevent disruption, yeah, that was one of the.
Fantastic. Thank you.
Can you hear me, Tracy?
Can you revisit the of getting bedside staff to give you feedback and how you managed to get them away from the bedside?
We don't get them away from the bedside because we go.
Okay.
So we go to the unit and we go to the people, and then after we do that, we have what's called site coordinators. The site coordinators then, when we're not on site with them, are invited to Teams meetings, and we talk with the Teams meetings, what the site coordinators have done at the bedside to get the feedback. So we bring it all, the project lifecycle goes all the way to the front lines. We don't have non-productive education time to take nurses out, and because of labor laws, you pay nurses to everything that they do. So we just go to them. It's a lot of work, but we go to them. It's a lot of rewarding too. So, I cover the whole state of Missouri, and a lot of people in this room have come to me and Renee as well, and talked about curiosity around ambient technology for nurses and saving time.
Yeah.
And so I'm just kind of curious from your standpoint and from you, and from everyone here, what have been like some of the biggest challenges that you've had when it comes to nurse adoption and your biggest surprises? Because you are a private review participant. Like, what are some of those pluses and minuses?
Yeah, so what's working well? What's working well are nurses have a direct feedback loop in line in the EHR directly to Microsoft around what's working well. That is phenomenal. So again, we're bringing all of that feedback loop directly to them in their 24/7 daily work. Utilization. So we don't talk about ambient conversational AI because it is in private preview and we're privileged to have the opportunity to co-develop. We don't talk about adoption. We talk about utilization. So utilization is not where I expect it to be, and I don't think it's expected where Cheryl or Kaylin expect it to be. So what I've done, where we thought through this, is to normalize utilization. Instead of talking about the number of raw recordings and the number of users, we are now speaking with the nursing leaders around what are the percentage of recordings per patient day. And I expect 5. 1 head to toe for the day shift nurse, 1 head to toe for the night shift nurse, and then 3 recordings for the UAP related to linens, bathing, walking, vitals, fuming, everything that they do. So that's how we're meeting them where they're at as far as an expectation goes. Because, for example, the I unit is a 35-bed unit and they've been census of 15. I have no idea why nobody wants surgery here, but they don't right now. Maybe it was an orthopedic med surg unit. It's the lowest that unit's been in a while. So when you look at raw recordings and you're like, oh my gosh, 23 recordings, we only had 15 patients.
Yeah, we didn't know where you were.
It's a totally different story. So utilization, we didn't take anything away. So this is all about building and designing on top of what you're currently doing. So we had a time and motion study, and we talk about short-term pain for long-term gain. So Ani was one of the supervisors who did a time and motion study, and she said, for a 6-patient team, we're asking them to spend 20 minutes longer documenting a day to give that feedback. And that's okay. Everybody's okay with that. So for a 6-patient team, 20 minutes longer, because it's short-term pain for long-term gain. So let's talk, my friend Carrie, NYU, and we talked about this with Sheila earlier today. She's the manager. Carrie and I were chatting, and they've been live a bit longer on private preview. And she goes, Tracy, my #1 nurse. So we're just gonna talk nurse, because that's what we just said. It's 20 minutes longer for a patient load of 6 for a mercy nurse. Carrie's been live longer. And Carrie said, my top nurse is saving 12 minutes per shift for a tune of 3 hours a month. So time saving. So that's why it's short-term pain for long-term gain. And they don't have LBA, she said. So, yeah. I hope that answer, so work well.
So, thank you, that's great. I'm curious, you guys have had such good results with the initiatives that you've already, excellent. You guys have had such great results with the initiatives that you've already taken on in the nursing area. So I guess kind of my question is really, what do you see next? I mean, AI is really kind of endless. It's only bound by what you want to do.
So my lens is nursing, and we have an entire AI team focused on the warehouse of possibility. So for nursing, what we see next is to continue the development for the larger clinical audience, and we have a team member in the back. Non-clinical work, clinical work with the ED to inpatient nurse handoff report. The model and the framework has given life to 5 different models for physicians. Yeah. And so Jacob was here a second ago. Carrie Bommarino and I spoke at the Arch Data Network, and we talked about those 5 additional models that were leveraged off of the first one for nursing. So I would say, if you're interested in understanding our AI portfolio, I need to connect you broadly outside of nursing, because my lens is nursing.
Perfect, thank you.
Going once. That's all you get once. Tracy, on behalf of our HIMSS Midwest Gateway chapter, thank you so much. All right, a little housekeeping really quickly. I believe we do ask if you would fill out a survey, and if you're so willing, let me see if I can pull that back up here. It's in the presentation. Might be at the end here. There it is. So if you wouldn't mind, scan the QR code. Take our survey. Let us know how we're doing. What can we do to make these things better as we move forward? If you can't get it from here, there are also little table stands all around. Feel free to scan one of those. Take the survey for
Okay,
us.
David, Ashley
Yes.
Rose here. Go ahead and move forward. This is Tracy's word cloud survey. So
My
go forward 2
apologies.
slides.
Sorry, it's post
Sorry
survey.
about
Let's see here. No, thank you for that. I want to keep going. And how about this one? No, maybe not yet. There we go. Sorry. Start that over again. So we love to hear from you. So if you would take our survey. No, thanks so much for being here. Again, now's the time for networking collaboration. Talk to people, learn what we do, what others are doing. I have a million questions for Tracy. I'm just embarrassed to get on the microphone and answer it publicly. There's also still food back here, and again, drinks are on the side. Thanks everybody for being here. Have a wonderful night. Drive safe.